right, I think we can get started. It looks like a lot of people are here. Thank you so much for coming and welcome to the Compumedics webinar series. My name is Kara Dykman and I am a sales and support representative for Compumedics Neuroscan in the US. I'm going to be your host for this third installment of the Curry NeuroTalks, and I also have William Oliver here with me, and he will help moderate the talk and also the questions as they come in. These NeuroTalks seminars, in these we hope to share research and clinical practices around epilepsy and other primary brain disorders, facilitate communication among scientists and clinicians, and inspire new advancements in the field. This is our third one. As I said, we're hosting these webinars on a quarterly basis. The dates, times, and registration information comes out in our Curry newsletter, which is also quarterly. We also send out emails and post on social media. So hopefully you have gotten the information in that way. Before we start, I just want to read a disclaimer to fulfill the compliance requirements of this talk, and I'll put it on the screen as well. Okay. The information in the NeuroTalks webinar represents the views and opinions of the presenter and does not necessarily represent those of Compumedics. Compumedics does not make any representations or warranties regarding the accuracy, applicability, fitness, or completeness of the information presented during the talks. The information presented in the webinar is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Compumedics does not seek product promotion, sales generation, or any other commercial value through this webinar. We simply want it to be a place for you to get and share information. And now it's my pleasure to tell you a little bit about our speaker for today. Dr. Vasileios Kokkinos holds 3 PhDs in the fields of neuroscience, clinical neurophysiology, and functional neuroimaging. From 2009 to 2016, he was head of neurophysiology and functional neuroimaging at the Epilepsy Center of Thessaloniki at St. Luke's Hospital in Greece. In 2017, he moved to the University of Pittsburgh as an instructor of neurological surgery. There, he supported their comprehensive epilepsy program with the integration of pre-surgical clinical neurophysiology and neuroimaging data, pre-surgical stereo EEG implantation planning, interpretation of intracranial EEG, and electrical cortical stimulation procedures. In 2019, Dr. Kokkinos joined Mass General Hospital and Harvard Medical School, focusing on clinical epilepsy research and providing his services to the epilepsy surgery program and clinical MEG program there. Since 2023, he's been with the Comprehensive Epilepsy Program at Northwestern Memorial Hospital. He's also an assistant professor of neurology at the Feinberg School of Medicine at Northwestern. He's board certified for epilepsy surgery neurophysiology and is a fellow of the American Clinical Neurophysiology Society. He'll be talking to us today about the interpretation of hippocampal intracranial EEG. Following his talk, we'll have a 10-minute question and answer session. Throughout the talk, you can post your questions in the question box, which some of you have found already. It's at the top of your screen. William and I will moderate those throughout the talk. We'll present them to Dr. Kokkinos at the end of the talk. If there's a break in the middle and there are some questions that have come up, we can present those at that time as well. I think that's it. But now, please join me in welcoming this distinguished researcher and clinician, Dr. Vasileios Kokkinos.
Thank you, Kara, for the introduction, and thank you to the Compumedics Neuroscan team for the invitation. It's my pleasure to give this talk. I'll start right away. Can everyone see my screen?
Yes.
Okay, thank you, William. So this is like one of my favorite topics, and I'm happy I was invited to give this talk on the interpretation of the intracranial EEG, and especially focusing on the hippocampus. There is no conflict of interest on my behalf related to the content of this talk. And my goals for this talk is for you to get um, uh, a recommended three-step process that I'm using. So it's a recommended process in order to review and interpret the intracranial EEG, irrespective whether it is focused on the hippocampus or not. Understand what we expect in general from the normal intracranial EEG background during both wakefulness and sleep states. Underground, what foregrounds entities, intracranial EEG entities that present in the foreground, specifically from the normal hippocampus. So this is the part that we're starting to focus on, the hippocampus, and then lay out, at least in my experience, four contributing factors that make the normal hippocampal intracranial EEG and four contributing factors to an abnormal hippocampal EEG. So let's start with where we're at. What's the context? The context is surgical planning by stereo EEG that is performed to define the epileptogenic zone, to study its relationship with functional areas, and to evaluate the possibility of surgical resection. It is necessary to make clear that there is a main surgical hypothesis to focus the exploration, and there is also an alternative hypothesis necessary to avoid sampling error. It's indicated to confirm the main hypothesis and eliminate the alternative hypothesis regarding the localization of the epileptogenic zone. And each electrode is justified by the clinical, electrophysiological, and anatomical evidence that were highlighted by the pre-surgical evaluation process. So once we have a surgical hypothesis, the patient goes to the operating room, the neurosurgeon implants the electrodes, and this is where the recording starts, and this is the topic of this talk. How do we proceed? What we actually do, and how we interpret the signals that we record from inside the brain. I would like to highlight the added value of combining stereo EEG with scalp electrodes during the SEEG investigations. This is a relatively safe process as long as we keep the scalp electrodes away from the stereo EEG contacts, and we use what we call a modified 1020 system. So the electrodes are slightly moved from displaced from the for their original positions to a position that is safely away from the stereo EEG electrodes. And I will give you like a brief example of why this is valuable in interpreting the intracranial EEG. I'm going to show you 5 pages of intracranial EEG and 5 pages of its corresponding scalp EEG. So this is for one of our patients. You see this is like a background. It's rather slow, and at this point, this is the second page, there is like something that looks like a spike, an abrupt spike, and after that there you can observe some rhythmicity developing in some of the contacts over here. You see this rhythmicity that's also shared by more than one channels. And then this rhythmicity continues, it attenuates in amplitude and kind of diminishes here. So what was that? Could this have been a seizure? I mean, it met some of the criteria for the seizure. It had an abrupt onset, and there was rhythmicity, focal rhythmicity developing in some of the channels. Well, if we look at the scalp electrodes, we will see before that event, we see the background of REM sleep. You can appreciate here the eye movements. You can appreciate the beta bursts here in the background. And at the moment of that spike, we basically see an arousal. So this is a REM arousal, and all arousals contain some rhythmic elements, and which is depicted here in the prefrontal electrodes. And then after that, the patient goes back to REM sleep. So what could appear as a seizure or suspected seizure might be like totally benign when we look at the extracranial EEG. And the reason is like we have like almost 100 years of experience with solid experience with extracranial EEG. We've become very good at it. However, that we're still exploring the intracranial EEG. And this is my favorite topic. This is why I'm really happy to give this lecture on this topic. So personally, from my experience, I've developed a three-step process to that is, you might call it like a pre-processing procedure before starting evaluating the seizures of the patients. So the first step in interpreting the EEG is to set up a review context that will allow us to provide a meaningful review of the intracranial EEG record. For that, we will need the electrode map, which is a system of corresponding implanted electrode contacts to the anatomical locations of the brain, and the review montage, which is basically a system of presenting those signals to the reviewer, both the intracranial and the extracranial. Now, starting with the electrode positions, what we usually do after the implantation is get either a CT that are going to fuse with a pre-op MRI. And in some centers, especially if they have low-intensity scanners of 1.5 Tesla, they can do post-op MRI directly. As you can appreciate here, the intracranial artifact of the stereo EEG electrodes without the need of fusion. Then what we usually do is electrode registration. So we basically mark with spheres the locations of each contact. This can be done by manually, contact by contact, or can be done like automatically with library-based electrode reconstruction, which is faster and easier. At the end, we have a digitally navigated 3D map of the brain that includes the electrode locations and their contacts. And this allows us to understand where each electrode has been placed and what anatomy eventually it covers. And after that is where we construct the electrode table that has rows of the representing the electrodes placed, and columns are how many contacts each electrode has. And in between, we have the anatomical locations that are that each contact is recording from. For example, here I prime is in the temporal pole, and its first 6 contacts are in the gray matter of the temporal pole. Then these ones are in white matter, and these last ones are in MTG space, middle temporal gyrus at the entry point, and so on and so forth. And this is the one valuable tool to understand what we are recording and where we are recording it from. Now, another important aspect of the interpretation is the montage. And one thing that is, I think, very useful in setting up the review is to have it in an anatomically convenient order. So this is, for example, a temporal plus coverage. And for example, so a temporal plus means that it covers the temporal lobe and some extra temporal locations. So for example, in this case, I would have the temporal pole on top, then the amygdala, then the anterior hippocampus, then the posterior hippocampus, and then the basal temporal, which is behind the tail of the hippocampus, and then the insula, which is the extracranial electrode. So in that case, I'm creating a gradient, an anatomical gradient from anterior to posterior in the temporal lobe, and then at the end I have the extratemporal locations. Another example from a frontoparietal implantation. So I would have the superior frontal gyrus on top, another portion of the superior frontal gyrus maybe a bit more posterior, the precentral gyrus superior then inferior, postcentral gyrus and the superior parietal lobule and the inferior parietal lobule. And that way I have a gradient anterior to posterior in the frontal lobe, and then I have 2 gradients in the parietal lobe, anterior to posterior, and then in that superior to inferior. So that is really convenient in orienting anatomically as we read the EEG signals. The electrode montage is something that is an issue or let's say a matter of preference. Also in the extracranial, this is why we have several montages every time we read the EEG. And the most popular ones are the bipolar and the common average referential. So the bipolar montage, it's the same. What goes for the extracranial, the same thing goes for the intracranial. It is less prone to the noise artifacts because it subtracts the noise. High signal to noise ratio in a bipolar montage. However, the subtraction of common intracranial EEG signal can reduce the information that we retrieve from the EEG. And let's do an example. So this is the recording of an electrode implanted in the amygdala. You can see here, you can appreciate in the more distal contacts, derivations A1, A2, A3, A4, and A5, A6. You see a spike wave discharge that seems to be phase reversing somewhere here in A3, A4. It's a bit unclear. You can also observe that the EEG background here is kind of suppressed, which is weird because the deepest one has a more mixed frequencies profile, and same as the lateral. So if we were in the extracranial EEG, we would say, okay, there is notable suppression here, and there seems to be phase reversal. So perhaps the heart, let's say, of the irritation here is between A3 and 4. However, if we switch to the referential montage, which is unfortunately more prone to noise artifacts, but it preserves the common intracranial EEG signal, for the same exact spike, we see different distribution. We see that the maximum spike is actually in the deep and creates a very nice gradient from mesial to lateral in the amygdala. So in any case, my recommendation is to choose a specific montage and then shift between the montages to understand what is the best interpretation for the spikes or other abnormalities that we see. Now, going to more details regarding the intracranial background of the hippocampus. Until maybe 2 decades, 3 decades ago, most of the information that we had from the hippocampus was indirect. The reason is that because the most popular implantation was with grids and strips, and those strips would cover the base of the temporal lobe. That means they would pick up signal from the parahippocampal gyrus, and maybe if they went deep enough, maybe the entorhinal cortex, but they would never enter the hippocampus. So the recordings we are having from temporal lobe implantations in the temporal lobe, actually by grids and strips, actually contain very little useful information regarding the hippocampus. Our understanding of the intrahippocampal signal came and took off basically with a stereo EEG that gave us the ability to place the electrode inside the parenchyma of the hippocampus. I'm taking one step back to remind everyone that what we're recording from the intracranial EEG, same as the extracranial EEG in general, is not an activity of a single neuron, but the activity of a group of neurons that are layered in an organized manner and generate, and their synchronization generates a high amplitude electric field that can be picked up by our EEG electrodes. What goes for a stereo EEG that goes through a hemispheric gyrus, and this is a coronal section that I'm showing you, it's recording a really moderate neocortical activity. You can see it's passing through a really narrow area here, and maybe contains one or maximum two two contacts. So it's really minimal. And then there are also these deeper contacts are picking up activity from the walls of the adjacent sulci. However, that signal is often high pass filtered because of the white matter that resides in between. Moreover, at the entry point where we are recording cortical activity, that cortical activity is generated by corticocortical connections. And although these electric fields are vertical to the stereo EEG surface, they can be opposing in direction and partially cancel out each other. So overall the signal will be reduced, and that results in what we call a moderate amplitude neocortical signal. This is an example of a SEG electrode implanted from the middle frontal gyrus to the insula. So these are the insular gray matter. You can appreciate the higher amplitude um, rhythms and oscillations here. And then we have white matter, where you see the signal is kind of suppressed. And then we get here in the middle frontal gyrus that has a clear neocortical signal, but notably less amplitude than the deeper one in the insula. Another example of a stereo EEG electrode that didn't get to its target. So you can appreciate cortical signal with mixed frequencies only in the more superficial contacts, and everything else looks suppressed because every other contact relies in white matter. Now, when we're placing a stereo EEG into the hippocampus, all of this is drastically changing. Because a stereo EEG electrode that passes through the hippocampal parenchyma is picking up more immediate neuronal activity, because it is very close to the main regions that form the trisynaptic circuit in the hippocampus: CA1, CA2, CA3, CA4, and the dentate gyres. And the MOSI fibers, that is the white matter that is in between, is really not comparable to the large white matter tracts of the neocortex. So it's reduced, and the filtering is less. Another factor that contributes to getting the signal from the hippocampus is that it's picking up high amplitude electric fields that are formed in the longitudinal axis of the hippocampus, that are formed from longitudinal networks of the CA1 and CA3 regions. So the result of this is that when we right after the implantation that includes the hippocampus, we open up our system. This is what we see. We see the intracranial signals from the hippocampus considerably higher amplitude than everything else. And although this is for the reasons that I've explained, this tends to bias us, because we're looking for abnormal signals. And when we see high amplitude signals, we are biased towards interpreting these as abnormal. So what I usually do is I normalize the intracranial EEG background. This is what I recommend as well, to give a fair to provide a fair balance between the signals for interpretation. So what I do is I select an rectal activity-free interval, so no spikes, like this one. And usually the system gives us this signal at 250 microvolts per millimeter when it turns on. And you can appreciate that the signals overall are pretty flat. If we had this signal in extracranial EEG, one would say, okay, is this ICU? The patient is suppressed or something. So the first thing I do is I make the background frequencies visible. So I increase the sensitivity to 100 microvolts per millimeter. And now I can really appreciate both the background waves and the background oscillations in all of the channels. Notice that in the anterior hippocampus here, the amplitudes remain pretty high and outstanding compared to everything else. So what I do next is normalize specifically the hippocampus signal. How do I do that? I go to the electrode map. I determine which electrode contacts reside within the hippocampus. So it's B1 to B5. And then I go back to the trace. I select these channels, and I reduce the sensitivity to 150 microvolts. So as you can see now, they all have kind of the same level as everything else. They don't stand out. So this is a more balanced way to look at the hippocampus. Since we're discussing the mesial temporal structures, the amygdala, which I think it deserves a separate talk all together, but I think this is an opportunity to outline this. So the amygdala over there is a nucleus, which means that the neurons that comprise the nucleus um, are not organized in layers. They have like a more like a spherical distribution, and that means that the amplitudes are not as synchronized as those of the neocortex or as those of the three-layered cortex of the hippocampus, and that results in lower amplitudes. So if we were to draw like a map of the amplitudes, the higher amplitudes we would see in the hippocampus, moderate amplitudes in the neocortex, and low in nuclei such as the amygdala and the thalamus. So, since we had to reduce the signal to normalize the hippocampus, in order to normalize the amygdala, we have to boost it. So again, I go to my map. I see which ones are residing within the amygdala space. In this case, is A1, A5. I go back to my trace, and I reduce the sensitivity, so I have 75 microvolts per millimeter, and you can see now, you can appreciate even the beta activity and gamma activity here in the background, as well as some sharp waves that previously were not visible. So now we can have a better appreciation of these background signals. Despite the manipulations that we did in sensitivity, you can see there are some flat channels here in the more superficial contacts of these electrodes. This means that these electrodes are outside the brain. So these channels, I think it's best to remove. And now we have like the ideal setup for review, since we have normalized everything. We're not biasing the amplitudes of the signals one against the other. So that was the first step with the electrode map and the review montage. And the second step in interpreting in my workflow is to evaluate the intracranial EEG background per anatomical location, which is covered by the implantation plan. Now, what do we know about the background of the intracranial EEG? Um, we have a very nice, series of very nice studies from the MNI group in Montreal, the epilepsy group at the Montreal Neurological Institute, that collaborated with a few other centers and got intracranial EEG recordings from stereo EEG, and they selected those electrodes that were not involved in the seizure, so we can call them normal. And based on these normal electrodes, they did a map of the normal distribution of frequencies in the brain, both during wakefulness and sleep. Specifically, let's start with wakefulness, where they found that beta and gamma frequencies predominate in the frontal regions, which matches what we know from the extracranial EEG. Also, that alpha has a posterior quadrant and pericentral distribution, which corresponds to the posterior dominant rhythm and the mu rhythm that we know again from the extracranial EEG. Theta elements have a diffuse distribution, and that delta is less often presented in occipital and pericentral regions, which is something we actually did not have this information from the extracranial EEG, so this is new. Specifically during wakefulness, the occipital lobe has the outstanding frequency range that dominates the background of the intracranial EEG is alpha. For the parietal lobe is a combination of alpha and beta. For the frontal lobe is a combination of beta and gamma. And for the temporal lobe is a combination of a more wider set of frequencies involving delta, theta, and alpha. So even in wakefulness, where we see on the extracranial EEG a rather uniform set of frequencies, in the intracranial, as you can see, each lobe has their own signature. And these signatures are even more uh, uh, separately distributed during sleep per region. So the same group looked into various microarchitectural elements of sleep, starting with the sleep spindles that we all know from the extracranial EEG. Just like the extracranial EEG, we have fast spindles in the intracranial EEG as well, 13 to 16 hertz. They were found to be maximal in the superior parietal lobule and the mesial parietal lobule, as well as the precuneus. Whereas slower spindles that have a more frontal distribution, they found to be dominant in the anterior frontal lobe, as well as the mesial frontal lobe and the cingulate. Then to non-REM delta activity, they seem to predominate the parietal and anterior insular regions. Now, that information regarding the anterior insula we couldn't have had without intracranial EEG, and that rate increases during slow wave sleep. Now, more specifically about specific regions that stand out during these stages for non-REM 2, the mesial occipital lobe has increased theta during non-REM 2. The inferior temporal has a really outstanding spike in theta and alpha frequencies, and the hippocampus in non-REM 2 has a predominance of delta activity. Respectively, in slow wave sleep, the mesial occipital lobe has like a prominent spike in theta activity, the mesial superior frontal in alpha. The middle cingulate surprisingly has a wideband increase from all frequencies to theta and gamma, which is pending explanation. And the hippocampus now has, on top of delta, as the sleep deepens, has also theta. In REM, the mesial precentral regions have a combination of delta and theta frequencies. The mesial occipital lobe has a combination of theta and alpha. Reminder that before in non-REM had only theta, now it's complemented by alpha. And the basal inferior temporal, which is like a continuation of the temporo-occipital network, also has a combination of theta and alpha as a peak, and the mesial temporal structures now, before they had delta and theta, now they're complemented by alpha. So to recap regarding the background of the hippocampal background activity, delta, alpha, and theta mixed frequencies dominate the background during wakefulness. When going into REM 2, the predominant background frequency is delta. We're going to slow wave sleep, theta activities present along with the delta. And when going to REM sleep, the normal background of the hippocampus is a mix of delta, theta, and alpha frequencies that you can appreciate is more or less the same mix as in wakefulness. The power of the delta band, and this was a surprise in this study, was highest in the amygdala and hippocampus during REM sleep. So compared to the rest of the brain, the hippocampus and the amygdala presented with a higher ratio of delta activity. And finally, in the hippocampus specifically, independent spindles with average frequency more or less like the ones that we are recording extracranially at 12.6 hertz were presented in those healthy hippocampi. And now that we understand a bit better the intracranial background EEG, we can move forward to interpreting the foreground elements of the regions that are covered by the implantation plan. And here we will focus on the hippocampus. So what do we mean by foreground and background? In photography, background it's what's on the back, foreground is what comes in closest to the camera. So in the intracranial EEG, the foreground is comprised of waveforms that literally stand out of the background. And those can be intracranial EEG variants or distinct waveforms, or interictal epileptic activity like spikes, sharp waves, spike wave discharges, etc. So in this talk, we will only focus on the intracranial EEG variants, the normal variants. We talked about the sleep spindles, and I want to make a pass to the hippocampus through that. So just like in the extracranial EEG, we're recording from the frontal lobe, specifically the anterior frontal lobe and the mesial frontal lobe and the cingulate, slow spindle activity, and from the parietal lobe, faster activity, 13 to 16 hertz. However, if we go to the temporal lobe, and this is something we already knew from recordings with grids and strips, there are no organized sleep spindles anywhere in the temporal lobe during non-REM sleep or um, throughout sleep. So while the rest of the brain, including the frontal lobe, the parietal lobe, is spindling, the temporal lobe does not follow. And this is something we can verify even now in our recordings. For example, this is a frontotemporal recording. So in blue are the contacts implanted in the frontal lobe, and the red ones in the temporal lobe. And you see these buzzes here uh, appearing rhythmically during non-REM sleep. Those are spindles, and you can appreciate that there's no such activity anywhere in the temporal lobe. I'm doing a zoom in here with between um, the frontal lobe contacts and the temporal contacts, the more representative ones, the temporal pole, the amygdala, and the hippocampus. You can appreciate while the frontal lobe generates spindles, there's actually nothing of that sort going on in the temporal lobe. And this was again investigated by the MNI group. So what they did is they selected spindles from the scalp, and they marked them, and that marker was used to evaluate if there is any synchronous activity in the intracranial EEG. So these are the marked spindles. Some of them, a group of them is frontocentral, and another group centroparietal. And when they tried to see if there was any synchrony, specific synchrony, consistent synchrony inside the brain, they found none. So they interpreted this result that the spindles in the scalp have a widespread cortical distribution, and with the highest percentages involving the centroparietal, lateral, and mesial cortex, whereas in the temporal, lateral, mesial structures, there was either low or no simultaneous increase in these frequencies. So the intracranial involvement during the scalp spindles has no consistent pattern and had low synchrony across the brain regions. So basically, what we understand as non-REM sleep spindle has a pretty broad cortical distribution. However, a separate entity called hippocampal spindles was also identified. They were shorter, they were spatially restricted in the hippocampus and had low synchrony, even they had lower non-synchrony with the sleep spindles that we record extracranially, but even lower synchrony even within the temporal lobe. So this is one of the most, um, uh, this is the first hippocampal variant that was acknowledged, and it is one of those variants that consistently come up in the hippocampal EEG background. So the hippocampal spindle, these are two consecutive pages from hippocampal spindle from the hippocampal signal, including hippocampal spindles. This is how they present morphologically. They appear exactly just like the extracranial scalp spindles. However, they are distinct. They are distinct both from the extracranial that we record, and they're distinct from also those intracranial entities that appear in the frontal lobe and the parietal lobe. The activity is confined in the hippocampus with low synchrony to the rest of the temporal lobe, and they do not have an extracranial correlate. Basically, they do not appear on scalp EEG. So the Montreal group also did another study investigating the rate of those hippocampal spindles with interictal activity, and they found that the more interictal activity increased, the less spindles were presenting. So they concluded that this is probably a physiological entity, the hippocampal spindles, which is diminished in epilepsy because the interictal activity is affecting them. A few years ago, and while I was at the Mass General, we teamed up with that group, and we decided to perform an incident study. An incident study is a study where you take two groups, that has a specific pathology and one pathology-free group, and you're trying to identify it is if a specific entity has specificity with one group or another. And we had a group of 75 patients for that comprised eventually, because some of them had bilateral SEEG performed, bilateral temporal. We were dealing with 102 hippocampi. So some of these hippocampi were epileptogenic, meaning that they initiated the seizures, and some of them were not implicated in the generation of the seizure, and those we would call like normal. And so the incident study um, resulted in the hippocampal spindles appearing equally both across the patient groups, which were temporal lobe epilepsy groups, temporal lobe epilepsy plus, and extratemporal lobe epilepsy. So there wasn't a group of pathology in the patient level that favored the presence of spindles, but also between the epileptogenic and non-epileptogenic hippocampi. We also investigated the surgical outcome, so Engel class 1 patients, that is successful surgeries. The between all those groups, the hippocampal spindles occurred with similar incidents. Not surprisingly, after this, even for those patients that failed the surgery, that they didn't have a good control after surgery, the hippocampal spindles also occurred with the same similar incidents, proving that hippocampal spindles are like a normal entity of these of the hippocampus in these groups. Um, Another variant that was discovered lately was the hippocampal bark. When it was first discovered, this was interpreted as a polyspike, but when using scalp electrodes, we often noticed that these were occurring at the same time as the well-known extracranial variant, the 14 and 6 positive spikes variant. So we started an investigation, a systematic investigation of this entity. We named it a bark because it reminded us of 18th century ship with masts. And we identified three subtypes. 14 hertz only subtype that you can appreciate here in the hippocampal background. Also notice these are spindles, and you can see like the vast difference in amplitude between hippocampal spindles and hippocampal barks. So this is the 14 hertz only subtype. We identified a 6 hertz only subtype, and a mixed one that always started with a 14 hertz and then evolving into 6. We had to like set some criteria just for the 14 hertz only subtype because it shared the same frequency with the spindles. So the basic three criteria for discriminating them is that the amplitude is like pretty high for barks and lower for spindles, and this can be anything between 5 to 10 times higher. It's highly asymmetric with the spikes going in the negative polarity more than the positive, whereas the spindles are rather symmetric. And of course, the paroxysmity, the barks, which were often mistaken as polyspikes, are really spiky, whereas the spindles are rather smooth sinusoidals. Now, the hippocampal barks appear independent or synchronized between the two hippocampi. So they can appear synchronized here in the between the right and the left hippocampus. They can present independent right without here on the right without a left correlate, and vice versa on the left without a right correlate. And they tend to be generated in the posterior hippocampus. So this is a recording with right hippocampus anterior 1, 2, 3, 4 on the head of the hippocampus, and right hippocampus posterior 1, 2, 3, and 4 in the tail of the hippocampus. And you can appreciate the higher amplitude here, and it's hardly notable here in the head. And we group these in our patient groups into patients that had left, right, and bilateral implantation, and you can see that there is a consistent distribution, spatial distribution of these entities in the back of the hippocampus. Now, we also performed an incident study in order to see if there is some specificity with barks. More importantly, because they looked so epileptiform, so aggressive, they can be mistaken as polyspikes. And so we compared again their incidence in these populations. Again, they appeared equally in all syndromes: temporal lobe epilepsy plus and extracranial temporal lobe epilepsy. Also, both in epileptogenic and non-epileptogenic hippocampi, they had the similar incidence, like not statistically significant, with no statistically significant difference in Engel class 2 and 4 patients that did not have good control of their seizures post surgically. However, and to our surprise, my surprise, they were significantly more frequent in extratemporal lobe epilepsy patients that had successful surgery, which means that they were actual extratemporal lobe epilepsy patients. There was no epilepsy involving the temporal lobe. So what that means is that if we see in the intracranial EEG barks, it means that most likely we're dealing with a healthy hippocampus, and that was a great marker to have. So now, in order to summarize everything and go down into those criteria that I have set for through my experience into what constitutes the normal and abnormal patterns in the hippocampus. So, regarding the normal elements, the intermittent and prominent background delta activity that can manifest either with moderate amplitude, prolonged delta wave sequence, or high amplitude, brief delta waves. That's something that is a normal pattern of the background of the hippocampus, both during wakefulness and sleep, including both non-REM and REM stages. High frequencies, mostly in the beta range, that are constantly present in the hippocampal intracranial EEG background, especially in wakefulness, even if they're overlaying intermittent delta waves. They are part of the normal presentation of the intracranial EEG background in the hippocampus. They're not some kind of paroxysmal fast activity. They're not like high frequency oscillations that can be interpreted as pathologic. These are the normal part of the hippocampus, both in wakefulness and sleep. And finally, from the normal variant perspective, the frequent or occasional occurrence of hippocampal spindles and barks during sleep, especially if you see both. And no-brainer, the absence of regular prominent interictal activity. That means that we're dealing with a normal hippocampus, especially if we see all four of them matching up. In a recording, it's high and likely that hippocampus is going to initiate a seizure. So on the flip side, an intracranial EEG background with abundant, near continuous or continuous delta wave activity that may or may not be rhythmic, so there is no interruption of the delta activity. There is no break where the background comes back to normal. It's near continuous or abundant. That is more likely to be abnormal. If that EEG background lacks high frequency components like beta and gamma components that can be transient or irregular, low amplitude usually, and thereby presenting as a suppressed intracranial EEG background when it's normalized, of course, is more likely to be abnormal. An intracranial EEG background that lacks or has notable reduction in those distinctive foreground elements, such as the hippocampal spindles or the barks, is more likely to be abnormal. And I would say barks are less likely as a biomarker because they present up to 30-35% in the population. So 65 to 70% of the times they will be absent anyway. But the hippocampal spindles have something between 85% and 90% presence in the normal population. So if they are not there, it's more likely that this is an abnormal hippocampus. And finally, if the EEG background is really overwhelmed by interictal activity to the degree that the background is hardly appreciable, that's most likely abnormal. I will give you some examples for that. So this is the normal background of wakefulness, where here in the hippocampus, so these three channels are in the hippocampal parenchyma of the head of the hippocampus, and those are in the tail of the hippocampus. So let's focus on these three too, just for the example purposes. So you see like transient delta activity that can be individual or semi-rhythmic, sometimes overlaid with beta here or some alpha activity here. This is how the uh, hippocampal signal in wakefulness looks like. So usually if you would see this in extracranial EEG, you would say, okay, this is LERDA, so lateralized periodic delta activity, which is a marker of pathology. In the hippocampus, it is not. It is actually normal. And then when you go to non-REM sleep, you see the background still has the delta activity on the back, and is complemented by spindle activity. And we may have some transient delta waves here overlaid or not overlaid by alpha or theta, still part of non-REM. And in the deeper sleep stages, like slow wave sleep, this delta activity can be more persistent and still overlaid with spindles and other faster background rhythms. Still, it's normal for the hippocampus. And if you see something like this, don't be fast to say that this is a polyspike. Indeed, it does look like a polyspike. This is a hippocampal bark, and you can see it maximizes its amplitude in the tail of the hippocampus and has a gradient to the head. Now, the abnormal EEG, so this is a case of a patient with severe right hippocampal sclerosis. You can appreciate the atrophy of the hippocampal head and the increased flare signal all the way back to the tail. It also presents with marked asymmetry in the PET with the marked hypometabolism here along the hippocampus. And this is the signal from the head of the hippocampus. Here in orange, and in green it's the tail of the hippocampus. So you can appreciate that you have nearly continuous delta in both regions, and without interruptions, and there is no clear background. The background is pretty flat. We don't see distinctive faster frequencies, beta or gamma frequencies. We don't appreciate normal elements. In the tail, you can appreciate something that might look like a spindle, might look like a bark, but you can see it's biphasic. It's not organized. It doesn't have the symmetry of any of these. So these are actually polyspikes. And at times where the interictal activity, the spikes are really, really frequent, it's like impossible to appreciate the background, like here and here and here. So this is what a really abnormal sclerotic hippocampus looks like. And with that, we conclude the third part of this process. And what we do now is, usually we wait for seizures. But thank you for your attention. I hope this was helpful, and for everyone to understand a process of appreciating the hippocampal EEG and what elements to pay attention to. And I'm ready for your questions. Thank you.
Thank you. I think everyone appreciated your talk, and would like to thank Dr. Kokkinos for his talk. I was summarizing it while you were speaking, and you just said all the things that I was summarizing. But I wanted to say that your talk really highlighted the importance of intracranial EEG for getting information about the hippocampus and other medial temporal regions, but also really importantly for the audience are the practical considerations of both placement of those stereo EEG leads and also interpretation of the data that you record, and how you need to be careful and conscientious about how you interpret and look at that data. And I really think that this type of recording will allow clinicians, and obviously has allowed you and your colleagues, to start determining what constitutes both normal and abnormal activity in your patients. So that was really great, and I really appreciated it as a non-clinician. And we will open the floor up for questions. I think William might have some in the question box, and if you have a question right now, feel free to type it into the question box.
Yes, we have a question from Shruti A. Could you comment on differences in ictal patterns of seizures from the hippocampus?
This is really not the topic of this talk. So this talk was focused on the normal elements of how to appreciate the background before going into the ictal elements. So the importance of understanding these background elements and foreground elements is because a really abnormal area will have an abnormal background. It's like the way that we understand epileptogenicity is virtually impossible for an area to that generates seizure, that has been involved in generating seizures chronically, like throughout years, to have a really normal background. When you appreciate a background that is abnormal, just without having seizure, okay, so this is an indication of that area being definitely abnormal. And why is that important? It is important because sometimes we're doing a sampling, the sampling that we're doing with stereo EEG and with subtemporal and grid electrodes is limited. We're only covering a part of the brain. So this appreciation of the background of the hippocampus and other areas is important, because we have to discriminate between ictal activity that actually originates in a really suspicious area just based on the background elements and foreground elements in the interictal EEG, and not just from the seizure, because when we're recording a seizure, it's by definition is not clear whether we're recording the exact spot or a really nearby neighboring area that is where it's propagated fast from the original that we're not recording from. And the such so this was the main point on how we use that to interpret afterwards the seizures. Now the ictal patterns, really this is a totally different talk that will take another hour. I would happy to give it in another time.
Okay. And I'm curious myself, in what ways do you believe, placement-wise, that standardization is important? Do you have a set of targets that you think should always be included in a stereo case? I feel like there's struggle between standardization and what the needs of the patient are. And I'm wondering what your own opinion might be on where stereo electrodes go and how we might be able to standardize that across patients and subjects in research.
Yeah, I think between standardization and individualization, there is always like a balance to be kept. On the side of providing personalized and individualized medicine and surgery, the epilepsy itself is so individualized that by definition, standardizing it would not be approaching it in a manner that is what's the best way to describe it, that aligns with the nature of this disease. Epilepsy can appear in any place in the neocortex. It can have any conceivable distribution, either as a unique patch or as separate patches, both in the same lobe, or spanning several lobes, or spanning both uh, hemispheres. So in that respect, standardizing it would beat the purpose. On the other hand, the more we understand about epileptic syndrome and how they manifest, the more we tend to improve the way we're addressing those syndromes. For example, a very well described syndrome is that of mesiotemporal lobe epilepsy, and we have, I think, more than 70 years of like good understanding of this syndrome and how it manifests. And in that respect, even now we have a pretty standard way of implanting patients that we understand that more likely are suffering from this syndrome. So we're covering the temporal pole, the amygdala, the anterior hippocampus, the tail of the hippocampus, and then some groups prefer a basal temporal, like a electrode just for posterior coverage. So that would be like a standard um, implantation for that syndrome. However, given the fact that in the surgical evaluation there is always, almost always, something that is, let's say, outstanding from on a case by case basis, this standardized template is complemented by other, let's say, non-standard um, coverage. And at the end, no two stereo G implants, even if we're dealing with the same syndrome, no two of them are identical. Hopefully
Okay.
that answered your question.
It does. We have a few. We have about four. I'm just going to start with the next one. Uh, have you looked at patients with RNS to bilateral hippocampi and described what are related to absence of seizures? Do they have barks and spindles? Because a lot of patients have bilateral temporal epilepsy or epileptiform abnormalities, and this is asked by John Eden.
Yes. So the problem with RNS record. So to the first question is yes, yes. I have processed data from RNS patients recorded bilaterally, and the answer is yes. We see barks. Yes, we see spindles. Yes, we see background delta, and we see the more or less the same differences in these groups, because sometimes we're implanting bilaterally those patients, and one of the hippocampi turns out to be not so active after all. And the problem is that the recordings of the RNS are really short. They're like 90-second snippets that basically represent, like, really very brief intervals of the whole recording. So although we see them in RNS, we cannot perform like a really comprehensive study, because we're basically missing 95% of the signal, like on an overnight sleep or a 24-hour interval. So that's the limitation with RNS. The understanding that we have for the RNS recordings really comes from the stereo EEG, that is 24-hour recording, and then we can go in the, like, we implant the patient with stereo EEG, we appreciate the entities and everything that we see in the hippocampus, and then when we place the RNS in the hippocampus, having seen what we've seen in the stereo EEG, then we can interpret what's going on in the RNS recording.
Excellent. We have a question from Jay Singh. Do you look into interictal infraslow wave activity? Is there any significance there?
I haven't. Usually the clinical amplifiers have a low frequency filter of 0.5. So we cannot appreciate like the sub delta frequencies very well. So I don't have much experience of that, but it would be definitely very interesting to see their distribution in the intracranial EEG of the hippocampus. That would be a great project.
We have one from John Eaton. At your institution, if there is no suspicion for bilateral epilepsy, are you generally implanting bilateral hippocampi? How often does the thought to be healthy, quote, hippocampus end up looking abnormal or epileptogenic?
Great question, and the answer is that. So the answer to the first question directly is a no. So the primary, if the temporal lobe is nowhere in the either in the primary hypothesis for implantation or the secondary hypothesis, uh, the temporal lobe should not be implanted at all. However, this varies between centers, and I have served in several epilepsy centers, and based on the physician's training and their experience with patients, there are some centers that will abide to the hypothesis and say, okay, we have no data that the hippocampus is implicated. We will not implant the hippocampus. There is another school of thought that says, yes, we don't have any data, but the hippocampus is a major component of the limbic system. It's a base. It's a like uh, is a structure that is either primarily or secondarily involved in loss of consciousness. So when you have loss of consciousness in the among the semiology, at some point you start suspecting that the hippocampus is involved. So there are elements that might not be presenting in the hypothesis, but let's so their way of thinking is that let's implant the hippocampus for monitoring purposes to see if it is somehow uh, because it's deep, it's mesial, and sometimes the EEG signal in the presurgical evaluation, which is non-invasive, that signal may not be picked up. So the hippocampus might be involved, but this would not be apparent on the EEG. So uh, the thought is let's implant the hippocampus, even though it's not in the hypothesis, just in case it is involved, and we can address this with an anterior temporal lobectomy. So it's a um, it's a school of thought that prioritizes experience from other from their past cases in combination with a rather standardized surgical treatment. I have worked with both, and I can say that I really prefer the evidence based approaches.
Great. Well, I think we could probably stay here all day asking
Totally
questions.
in the
I'm
same.
fine. Works for me.
Yeah, thank you for the wonderful talk. I would also just like to quickly read. We just have some comments just thanking you for for the great talk, and people are interested to hear more about abnormal hippocampus. They are thanking you for standardization of workflow and data analysis and how important it is. So just a lot of really good comments. Thanking you like we are thanking you. So the audience appreciates it. We appreciate your time and speaking with us today.
Yes, and we also appreciate the audience. So we thank everyone for coming, and we will have another webinar probably early December, and you will get information both in the newsletter and through social media and email flyers. So look out for that, and maybe in another time we'll have Dr. Kokkinos back to answer all of these other questions that you are
Yes,
all
please.
interested in. Thank you so much.
Thank you.